with us this morning to discuss upper extremity return to play. He's going to go through a battery of tests that he's done, as well as introduce some of the things that have started to come up in literature and practice. For those that you don't know, Niles has been at Wake Forest for 4 years now. Niles, 3 or 4 years?
Six years.
Close.
A long time.
All right, so he's been at Wake. He's their rehab coordinator as well as a football athletic trainer, so works with all of their sports teams, and he's going to discuss kind of the ways that he integrates return to play decisions with the Demon Deacons out there in Winston-Salem. So with that, I'll let you take it away, Niles, and you can start to share your screen.
Yep, sounds good. Give me 1 second here. All right, can everybody see that okay? Good. So I was telling Ryan, this is a little bit of a modified presentation I've done a few times. I just wanted to update it with some of the current stuff that's coming out in literature. Return to sport testing and functional testing for the upper extremity is still a newer concept. It's something that I think is important, just like I think with every testing that we do. I think we make it specific to our athletes. I think we just need to do more than just a CYA, but actually make sure that they feel safe and confident and that they can do everything that they need to do for their sport. So I'm going to review just kind of a quick background of stuff, and then we'll kind of get into it. If anybody has questions, feel free to interject. I think we have a smaller group, which is kind of nice. So if we have questions, feel free to interject. I can bring them up, and we'll try to answer them as we go. So just kind of roll with that. Otherwise, we'll just kind of answer them at the end. So all stuff that we consider with return to sport: tissue healing times, pain, range of motion, strength. We look at the growth strength. We look at ratios, endurance, power. All this stuff is really important. Big things that I consider with my return to sport, and these are just a few of inside the healthcare realm, as opposed to thinking over the global, and I'll kind of discuss it at the end as well with our return to sport testing and all of the considerations that go into it. First of all, this is a multidisciplinary approach. People read these decision-making articles, and it's either from physician guidelines, or it's from a physical therapist, or it's an athletic trainer's statements. I just want to reiterate, this is a multidisciplinary approach. This is by no means what I have here, and what I'm presenting today is not the end-all be-all. It's just kind of the best literature that we have to date. I like to include this picture. It's one of our athletes who went down with an injury. The picture's funny to me because we have our team orthopod, we have our team primary care, we have obviously our head football coach, we have 2 athletic trainers, and our director of football ops is out there. And it goes to show you that everyone who was involved in an injury from the start, and the DFO is out there because he wants to find out how serious it is, so he can notify the parents immediately to make sure the family is involved. So it's all kind of making sure this multidisciplinary approach, everybody revolves around that student athlete and trying to make sure it's a collaborative effort to return them. So that going into this, no need for this talk to spend time on the tissue healing times. We know it. There's a lot of literature out there. This guides all of our decision for when these tests are introduced. And so that's the one thing I would kind of think about that as you're going through your testing batteries and thinking about these different tests that I'll be showing you. Knowing your tissue healing times is important. I say that you can do basically any rehab as long as you understand the tissue healing times and the stress that it puts on a certain area, and you understand the biomechanics. So that's kind of my caveat with that. Pain, I'm not going to really talk about it. This is a big topic when you think about especially elite athletes. What is okay pain? Return to sport after surgery, I like to have no pain, but at the same time, I understand they're going to get soreness and they're going to have some kind of stuff as they progress along it, and then maybe have some soreness and stuff with the testing. I'm just going to note it, and we're going to, as a sports medicine team, we're going to discuss what we need to do about it, how serious we need to take it, what the potential risk and all that kind of things are. Obviously, we use a lot of techniques to see if we can help with that, and sometimes some of these techniques will completely remove that pain. So understanding that is the big thing. Range of motion, I'm not going to harp on this. appreciate your norms within your population. There's a lot of studies out there, and this is, again, outside the scope of this presentation. Appreciate your norms. There's a lot of data. Knowing it for your little league pitchers versus your elite athlete pitchers, knowing it for your volleyball players, your tennis players, when thinking about upper extremity, and then knowing your baseline norms for your football players. Just understanding that is the biggest thing I want to harp on with that. So getting into some of the stuff that we do, obviously the functional movement screen is out there. I do use parts of it. I do not use it as a score anymore. And I'm not going to really talk about much with this because I want to get into some of the newer stuff. I think everyone is pretty familiar with the FMS, and I think it is a good tool to globally look at somebody and get an idea of how they move through a different series of motions. It also does with some of the shoulder stuff. You can kind of pick up some shoulder issues that may present in their sport. And I think, again, using it for what it was designed for as a quick screening tool is very, very useful. But again, it's not by any means the end all be all. Getting the strength, we do a lot with strength. Strength is one of the biggest things that I think is important with all of this, with all rehab. I think it all comes down to being able to be strong and have full range of motion. So typically the gold standard isokinetic, this article in 2011 really shows that position will affect it. So if you're going to do isokinetic testing, make sure you are consistent. Make sure you are using a reliable protocol. Obviously, there's a lot of costs that are affiliated with looking at using isokinetic testing. I think when I quoted one out, it was around $55,000. So they're not cheap. Even used, I think they're still around $30,000. So obviously, there's a cost associated with these. They do eat up a lot of square footage in your rehab space. So if you don't have a large training room or a large rehab gym, that is a downside to it. But again, it is still considered the gold standard. The reason it's good is, I mean, looking at someone like this Berkman's article, there's a lot of normative data out there on athlete populations, especially in the upper extremity sports. So this article kind of was a systematic review looking at all the different athlete data for upper extremities, and really did a good job of kind of breaking down concentric, eccentric. They actually, I only included on this slide the 60 degrees per second, but they did 60, 180, and 300, and kind of broke down what the peak torque to body weight ratio was, what the normal range was, and then the really good thing that I think they pulled out of this was the functional deceleration ratio, which is something I look about with my overhead athletes, my volleyball players, my baseball, my tennis guys. And so what they found, and I think this is a really good thing to know, is when you're looking at, you're testing these guys and you're looking at that functional deceleration ratio, that the actual dominant arm, that ratio is actually lower. And it makes sense because they're going to have a much stronger concentric internal rotation force as an upper extremity athlete. And their eccentric decelerators typically aren't necessarily stronger in conjunction with that. So typically their dominant arm, that ratio is overall typically lower than, say, their non-dominant arm. And this is in healthy populations. Again, there are other articles on ratios looking out there. This Stickley article in the Journal of Athletic Training looked at U12 to U15 and kind of showed what the normal ratio was, and then also kind of demonstrated that ratio was more associated with a previous injury with this study. So good use for isokinetic testing. I think it has its place, and it's really good data, especially if you're trying to cover the full spectrum of their strength and you want to get a little more data on it. The other scores that have been correlated with this Bourne's article looked at the seated med ball toss. This is a double arm throw. This is not the single arm, but it did show that it correlated well with it. Every study to that point, everyone compares to isokinetic testing, so it is the gold standard. Do we have a
Hey, Niles, yeah, Tony
had
just asked what was that position? Was it neutral or 90-90?
For which one? For the Berkman's article? For the Berkman's article, it was tested in the neutral position.
Do you know about the Stickley by any chance?
The Stickley, I'd have to go back and review that one.
Yeah.
I want it because I think the Stickley article is actually included in that systematic review, so I believe it's in the neutral position as well. The other way we assess strength is handheld dynamometry. This meta-analysis came out in 2014, so it's 6 years old. So take it for what you will. But it did include 54 studies, and one of the things that came up in it was it's not super reliable for the intra-examiner, so except for elbow. So I think as a result of this meta-analysis coming out, I think there have been a few more recent studies looking at trying to normalize the handheld dynamometry and trying to get it. What I found in all of these studies were most of the people that if you want to have a higher reliability with handheld dynamometry, you have to do it, and you have to do it consistently. You have to be familiar with it. You have to have a consistent protocol that you follow. If you're only doing it once every so often, yes, you are going to have a hard time using that data and using it effectively, especially from day 1 to day 2 testing. So I think that was the big thing that came up with that. And that's why I included that. It's not that I'm saying don't do it because it's not reliable. It's saying that you need to, in order to be more reliable doing it, you need to practice it. The article right there, that 2020 that just came out in Journal of Athletic Training, they actually used a new system called the self-assessment corner, which is basically a fixed handheld dynamometer. Again, there's several different devices out there. Personally, I like to use a cheap system that my fellow VN showed me using. We basically use a luggage scale, and I fix it to our we have a rack on the wall that I fix it to, and I'll test all of my shoulder positions there for a 5-second max isometric, and I just have a consistent testing protocol. Again, the more often you do it, the more often you standardize it, and then the better you are about teaching your athletes how to perform these tests, the more consistent your results are going to be. Going on to looking at that reference values that
Tim asked,
2016.
I'm sorry, Niles. Tim asked if you might have a picture of that. If not, I can definitely. I'm sure VN's got an article or some pictures on it, and I could probably send it out to the group.
For the Journal of Athletic Training.
Yeah,
my testing.
Yeah, the luggage scale setup.
I will grab a. Basically, yeah, I don't have a picture. I should have. It's been hard to, when I was putting this, I wanted to take pictures, but I'm the only essential person allowed on campus. And so it's been a little bit hard to put pictures in, so I apologize. I can include how we do that later. Maybe I can get some pictures. But yeah, unfortunately, I was not able to include that.
If not, I'll grab one from VN, I'm sure.
Yeah, when I do this talk, it's typically a lab mixed talk, so I apologize that there's not as many pictures in this as I would like.
This is awesome so far, so appreciate it.
But looking again, that Cools article, they gave reference values for tennis, handball, and volleyball athletes with a significant number. So there is good data using handheld dynamometry out there. The whole article of physical therapy in sport, they did a really good job looking at the comparison of using handheld dynamometry versus an external fixated device. So basically the dynamometer is fixed to something and doing your max isometric there. They found that handheld dynamometry was a little bit more reliable with a experienced tester, but both are reliable with a low enough MDC that you can kind of track change over time. And that's in comparison to isokinetics. So that article, I think, again, just solidifies the fact that don't throw it out just because there was one study that said it was not as reliable. Not saying that there's newer stuff, and the better you get at it and the more consistent you are, the better you're going to use it. Lastly, Marissa Pantillo, and I'm going to remember that name. Sorry, I'm sorry, Marissa. But she did a couple looking at this as well, and this was a battery of tests, but she included handheld dynamometry in both of these. In the first study, in the 2014 article, she did an external fixated device and got some normative value for football athletes and looked at injuries, saw that there was no strength correlations. In another article that just came out in Physical Therapy and Sport this year, she basically created a profile for Division I college athletes, and it was a battery of tests, but she included actually using handheld dynamometry as opposed to an external fixated device for all of these testings. And again, it gave a nice reference value for sport, male, female, etc. So again, there is good information out here, and the nice part about these kind of studies for me is when we are starting to enact this kind of stuff and I'm starting to get baseline tests and measures on our athletes healthy, it gives me a better idea of what they should be looking like. And so if I have a kid who had a shoulder injury who's a senior that I never got baseline numbers on him because this is a newer thing that we started, I have an idea of where he should be at. So any other questions on kind of the strength testing? Those are my main batteries for strength testing. Getting into power, the big test for power right now is honestly the seated shot put. It's been described in multiple different ways, and I think it's good to make sure you read the methods of a study that you're looking at, because when you do your PubMed search, you're going to see about all of these different seated shot put tests, and I need you to realize that you're not necessarily comparing apples to apples. Seated shot put test, the one that I think of when I hear that is a single arm, long sitting, and pushing it's about a 6-pound ball. It's a shot put as far as you can and comparing bilaterally. The test has also been described sitting with 2 hands, long sitting with your back against the wall. It's also been described sitting on a bench with your back against the wall. So make sure when you're reading these articles, know the methods. Don't just read the abstract, actually understand the methods, so that whatever data you're trying to compare to, you're comparing apples to apples. That's the point of that slide. Like I said, with my testing battery, I include the single arm shot put test. It's been shown to be highly reliable. There is studies looking at MDCs. So for dominant was 17 inches, non-dominant is 18 inches. This article in JOSPT in 2014 actually did a really good job of, again, looking at the differences, dominant versus non-dominant, and saw that there was about a 10%, between 5 and 10% difference with your dominant, non-dominant. So when you're thinking about your athletes for return to sport, knowing that when they hit that 90% of so if their right arm's affected, their right hand dominant, if they hit 90% of their left arm, they're probably closer to 20% away as opposed to 10% away. And I think that's just another good thing to kind of have in the back of your mind when you're thinking about that battery of tests. The nice thing about this one, as soon as they're cleared for throwing, or any kind of, it's not even a true throw, but as soon as they're cleared for a little bit of plyometric activity, you can start tracking this data. So with my labral repairs, I'm usually starting this right around the 3.5 month time period to start tracking it, and to also give them a familiarization with the test, so there's not as much of a learning curve as we're going. Like when test day hits, it's not the first time they've ever seen this. Newer tests for power that are coming out. This article was just published last year, I think. This DIE article was published last year in Journal of Strength and Conditioning Research, and they looked at doing a plyometric push-up. I think this is great. Again, it's not a low-cost alternative because you have to have 2 force plates. But I do think, especially at the elite level or a place where you can afford it, and force plates are fortunately becoming more and more affordable, this is something that I'm really interested in. Basically, doing a plyometric push-up, they lower themselves and then drive up so their hands break contact with the plates. And then they basically showed that it was reliable. So this is kind of the step one of their pilot study looking at this. And I think they're going to start looking at correlating with injury data in the future. But again, really something that I think will be really beneficial, especially for my athletes that I need to have, some of my football players, rugby players, people that I expect to be explosive. I use this with types of this training with any athlete that I think is going to hit the ground, mainly because I know that I want them to control that and feel stable and powerful in that position. So my basketball athletes get this as well, depending on the type of athlete they are. Another newer one that is coming out, I use the Kaiser, and by no means am I sponsored by Kaiser. I wish I was. It'd be great to have a little extra cash flow right now. But the Kaiser stuff has been really great. I use the leg press system for my lower extremity testing. I'm looking at expanding that to get a little bit of upper extremity testing as well, using the same software. Basically, you can see the machine there. If you're familiar with Kaiser, it uses air displacement, so foot pounds, and gives you powers in newtons. And with the testing that they do with this Air 420 system, is it allows you to actually track rate of force development, and you can compare right to left and actually get deficits. You can compare timing, reaction time, and several other things with it. So again, this is something newer on the horizon that I've been playing with. I've used some of their machines at demonstrations, and I've gone down to another facility and kind of toyed with the idea of using this for some of the battery of return to play testing. The same software can be used for the row machine where each arm moves independently. So you can almost test a pull and a push for the upper extremity and hopefully get a little bit more clear data for power for the upper extremity. Any questions about power? Are we good? Keep on rolling. Test for endurance. This article came out in 2010, so it's a little bit more dated. But again, I think the numbers are still good, and I think it's a good standardized test if you want to test for endurance for your upper extremity athletes. So all my tennis players that are coming back, I do both of these tests with them. Guys that I know are going to be using their arms a lot. Volleyball, my hitters, they all go through this endurance test. So the push-up test was described basically in two different ways. There was the sorry, not the typo, the 1 minute. It was, I believe it was 15. So I had to go back and check that. Sorry. I believe it was 15 seconds with 45 seconds off for 3 rounds for that. And then you also did the as many as you can do in the for exhaustion. So there's 2 different ways to look at the push-up test. I like to do the exhaustion, as many push-ups. And again, you have to be kind of the stickler for form. They have to go for the test 90 degrees at the elbows and then coming back up to full extension. It's not these little half pumps. And then it can be, it was described that it can be modified as well for females depending on your population. So that's what the push-up test. The modified pull-up test, kind of show you a picture of that. Basically feet up on a bench and doing a inverted row, an exercise that I like to do a lot in the weight room anyways, but 15 seconds AMRAP with a 45-second break, 3 rounds, and then kind of taking the mean on those. And there was some normative data on those as well, published back in 2010. So again, 2 tests that you can at least have something if you want to look at endurance. There have been other endurance protocols that have been put out there. I did not include all of them because I don't use them as much. These are kind of the 2 quick and dirty field tests that I do. Function and stability. So I kind of included these group of tests together. When you look at the CKC upper extremity stability test, it's been described in the literature a lot. It's been probably the most studied upper extremity test that I can think of, and then probably followed closely by the upper quarter Y balance. Basically, you have a strip of tape, 2 strips of tape, 3 feet apart. Your hands are just are at the tape, and you for 15 seconds you go and touch the outside of the tape as fast as possible, and you get 45-second break, and then you do it again for 3 rounds. I will say that in my experience, and then also in talking to Marisa with her athletes, especially her football athletes, there is a learning curve. And I think if you familiarize them with it and kind of they get used to that tempo and that speed, your first 2 tests are going to be on the low side, and then that 3rd test, and if you go again for a 4th or 5th test, are going to be higher, because there is a learning curve to this test that's been shown in a few different studies with day 1 and day 2 testing. But again, because this test has been studied so much, it does not give you a side-to-side difference, but it does give you their confidence and their ability to move quickly from closed chain position on one arm to the closed chain position on the other arm. And so I think there is a very good use for this test. And as well, there's a lot of normative data, especially in college athletes, which is my population, that I know my baseball players should be around this number, my football players should be around this number, my tennis players are going to be around this number. So for that reason, I think it's really important to include this test specifically. It's been shown to be reliable. They did a modified position, so instead of your hands on the outside of the tape, just your hands underneath your shoulders and still reaching outside the tape. And it's been shown to be reliable as well. That's that Holstat article. And then that Roush article actually showed that there's no difference with position players in baseball with this as well. So again, good, reliable test. I like to use it. It did show a moderate correlation with both the seated med ball toss, which was, again, the double arm, and the upper quarter Y balance. So I think everyone's familiar with this one. I think everyone has seen it and hopefully at least practiced it. It is fatiguing, especially by the time you get to that 3rd one. So it does have a little bit of that endurance protocol in there as well, especially for my big 300-pound linemen. It is fun to watch them do this after their labral surgeries. This is the modified position, so as opposed to being out wide, being underneath. I will say I typically end up using the modified position because my athletes just feel more comfortable in that position. Upper quarter Y balance. One of the more difficult tests in the battery. Again, it's been studied a lot. Dr. Butler, when I was a fellow at Duke not too long ago, wink, wink, I'm not that old. I worked with him a lot, and we discussed FMS Y balance, and I think he's with the Red Sox now. But looking at this, I do think it is a very good test for the upper extremity, especially dynamic motion for someone who may have had a instability issue. So it really pushes them to their limit, especially if our athletes are competitive. It's reliable. Really no difference between dominant and non-dominant limbs, and that's in a upper extremity sport. So one study was in baseball and softball players, the other study was in swimmers. But again, it showed it was consistent. So you can kind of compare side to side with the composite scores. The biggest problems with this, and this is what I've seen overall, is a lot of people have a hard time with the consistently getting and I don't know if it's maybe palpation issues, but people have a hard time palpating C7 and getting that limb length for the composite scores. And so I think that's another big thing that just, if you're going to do tests like this, you need to be consistent. You need to do them right. You need to measure consistently and understand what you're doing. So really good test. I do not necessarily do it with everybody, but I use it for all of my upper extremity athletes or people that are going to be in a closed chain position. Get a picture of it if you're not familiar. Single arm hop test, one of the most controversial of the tests out here, mainly because everyone thinks it's super crazy and unsafe to do, especially when I present this to general outpatient that don't see as many athletes as I'm used to seeing. Even my physicians get a little scared when I tell them I'm going to do a single arm hop test with their labral repair prior to them returning to sport. And then my answer to that is, well, you expect them to hit someone with probably over 300 pounds coming at them. For a football player, it's probably important that they can absorb this energy with their body weight. So as far as I know, this is the only article that has described it, and this is obviously an 18-year-old article. There may be more, and if there are, please educate me, because I'm interested. But she basically looked at this specifically with football and wrestlers as her population, and saw that basically 5% was her number. Again, my number's been closer to 10% with our healthies. And again, this is a great field test, super quick to do. It takes me roughly 3 to 4 minutes for this part of the battery. And again, once they have done it, it builds so much confidence in them for their ability to bear weight and force through that arm, that their confidence level and that return to play, I think, is really affected by this. And again, I will do this with, depending on the type of basketball player it is, they're going to, if they had a shoulder or elbow, even sometimes a wrist injury, they're going to be getting this test if they're one that is expected to dive on the ground, because I want them to have that confidence that they can bear that weight through that upper extremity. Does anyone else use this, not use this, have arguments against it? We'll just keep on rolling then. Oh, there's some chats.
I've used it in the past kind of for the same rationale when I was working in rugby. To your point of like,
and it is lateral.
Yeah. To your point of, I just don't think you have so many resources in the clinic. Everybody's got a 4-inch, step. My curiosity is, where does this look timeline? Is this pretty, like, when do you introduce this, like, post-op labral, posterior, labral on like a lineman? When do you think timeline typically for that?
Yeah. So this is something that they have to have gone through at least a body weight plyometric series, upper extremity. So like they've been doing plyometric push-ups, they've been doing hop-ups, and they've maybe done some controlled falls. That's when I will get the baseline test. But I'm definitely introducing this before I clear them for any kind of striking drills on the field, any kind of things like that. They're going to have to do this first. So again, timeline, tissue healing is probably closer to that 14 to 16 week period post-op for, like, say, a shoulder labral repair, based on, they should have probably began their plyometric between 10 and 12 weeks in there. And so it's probably closer to that 14 to 16 weeks where I'm looking at testing this. But again, it just depends on the individual as well.
Yeah, thank you. That's really good insight on timing.
So here's really one of the newer things that's come out. Came out in 2018. There was a really good article in 2019 looking at the ASH test, or the athletic shoulder test. This came out looking specifically thinking about rugby players and Australian rules football. Basically, one of the things we don't think about, or we don't really test for, is the ability to absorb weight in that really abducted position for a football player. So making an arm tackle, probably one of the most hard things on your shoulder. The amount of biceps I've seen ruptured trying to make an arm tackle in football, it's a very stressful position. And so one of the things that they presented was this ASH test. And so you can see the procedures there. I think it's easier if you look at the picture. But basically what they presented, and this is something, again, force plate, you have to have it if you want to be able to do this test. I think you could get away with doing it maybe with a handheld dynamometer. But again, the data has been shown with a force plate. So the carryover may or may not be there. You'd have to probably study it to get the reliability on that. But basically what they proposed was doing a I, Y, and T maximum isometric. And if you think about it, these are the positions that you're going to be in if you're making a outstretched arm tackle in one of these sports. So rugby and Australian rules football, and then obviously that would carry over to our American football as well, or possibly Red Rover for our younger athletes. So I thought this was new to me, and they were presenting some stuff, just some expert opinion tests that they've been doing with it, looking at guys that have passed basically what I would consider my battery of tests, and then performed this, and they're looking at the rate of force development on their shoulders and in these positions, and they're seeing a 10-20% decrease on their affected side versus their unaffected side. And again, I think the ability to do that quickly in response to making a tackle, especially for my collision sport athletes, is going to be something that I think is really, really important. And this is why I'm glad, and this is why I think this fellowship and residencies are great, is because it causes practitioners like me to get back in the literature and find out what is new and what is coming out, because I think this is something I would like to look at adding into my battery of testing as well. I think I saw a chat pop up there. That question.
Dan was saying maybe a bathroom scale for the poor PT with the TY testing there.
Yep. And so I think it's also important to note, and again, I put this in the presentation so you'll be able to see it later. But the positioning, if you look at that eye position, what they found was it was really hard to stabilize with your arm behind your back for that testing position. So they said for this one, your arm is at your side for the eye position, and then your other arm is behind your back for the other two positions. So again, if you're kind of looking at that standardized testing protocol, that's the way it's performed. And again, I wanted to do videos of all this to show you guys, and I apologize. Thank you, COVID, for nothing, except for these great talks that have come out of it. Another test that I think was really interesting as I was going through the literature is called the push-off test. This is actually made popular by hand therapists, and I don't know if anyone's familiar with this or they learned this in PT school. Maybe I'm just an old guy who graduated too long ago and didn't get this in PT school. But what they were looking at was a test that could be simple, easy to use with equipment that you probably have in your clinic already, that you could look at the patient's ability and confidence to bear weight through their upper extremity. And mainly they were concerned about the wrist and the elbow. And so what they did, I'll kind of show you the picture here, is they took a handheld dynamometer, they flipped it upside down and reversed the hand grip. And then basically you're doing a press up or a push off with a neutral wrist position, and you're recording the amount of weight. So you're basically instructing them to put as much weight as they can through that wrist. And what they saw, and this was studied in actually injured populations, but this did correlate with negative correlation with their DASH scores. So it did correlate with their DASH scores, but they also saw that it had really strong inter-rater reliability for the affected and unaffected arms as well. So again, I think it was a really good tool and something that I was not as familiar with. But again, I always try to gauge what my athletes' ability, and I think like when I throw in, like they start doing something along the lines of the Throwers 10 for their home exercise program, it does have a press up component in it. And so one of the things with my shoulders is some of the guys are a little bit uneasy to get in that position because it feels awkward to put that much weight through their wrist and hand early on. And so I think one of these things, and this could be done early on in the rehab, as soon as they're allowed to do closed chain activities, that you could start tracking their progress with this. So again, another really interesting test that has come out in the last few years. I say last few years because it's prior to me leaving PT school and fellowship and residency, that I think it really has a good application for us looking at returning guys to weight-bearing status in sport. Another new test that was published just this year, physical therapy in sport. Sorry. Another new test that was published just this year was the upper limb rotation test. And again, I think this was, it was interesting. I thought it'd be worth looking into because it was just published in this year. Basically, the athlete's in a plank position, and they feet are shoulder width apart. Their ankle, hip, and shoulder all against the wall, and then you put this line of tape right at their shoulders. And basically, you're asking them to rotate up, touch their opposite elbow to the wall as many times as possible in 15 seconds with a 45-second rest break. What you're looking for here is how many reps can they do, number one, and then what is their confidence in their ability to, again, rotate through a closed chain position. So again, another closed chain stability function test that has been presented. And again, when I'm looking at all these tests, I think about the ACL functional testing that started coming up 15 years ago. And I really think the shoulder is just a little bit behind. The upper extremity overall is a little bit behind on functional testing. But I think the more these tests are introduced and studied and the more you can start to do it, the better. One of the things that I am most concerned about is the amount of times that I hear about athletes or I'll get a freshman who came in off a shoulder injury who they had zero testing at all coming off their shoulder injury before they were cleared to come back, and they were expected to go full tilt day one in the weight room or in the football practice with 7-on-7s in the spring or something like that. And so and the amount of times I see stuff that I flag immediately that they need to work on before I'll clear them to play. So I think my takeaway message with these return to sport testing is just make sure that you're doing something consistently and looking at what's been published, because hopefully there will be more and more normative data on this as these become more popular and more studied. And so that's kind of the big test for function and stability that I have and that I've used. So before I move on, does anybody have any questions or comments about these tests? I know there's a lot in there, but I'm trying to get through it to protect everyone's time. We all good? So,
yeah, I mean, that was really comprehensive, Niles, so thank you. It'll be great to see kind of, I think, where you're going with this, how you integrate it.
So lastly is, again, when you think about return to sport, I would be remiss not to talk about an interval throwing or an interval sports program. There's a ton available online. If you look at this list of references, there's plenty of programs out there, so there's no reason not to have someone on a program. Right now, it's been crazy. I have a picture coming off of Tommy John, who's going through his return. He's supposed to be coming off a mound, and his biggest issue is he can't find mound time. So we've been trying to solve that problem. But again, I think you take those programs, if you are familiar with periodization and the ideas that went into those programs. If you're going to modify them, I think you just got to make sure you're modifying it appropriately. Be familiar with it. Don't be afraid to ask your physicians, and don't be afraid to reach out to these authors on these articles, because again, when they designed these, the idea behind them was to make sure that we're returning people safely. I have taken one of these and actually modified it, and I've seen it published now as well, is looking at a return to throwing for jab, because that was one thing I was not familiar with, but apparently Tommy John with jab throwers is pretty common as well. And so that return to sport progression, thinking about those athletes, is going to be different than what you're thinking about with your baseball throwers or your softball throwers, or even like a infielder for baseball. So just making sure you kind of use those. Another thing is, when I say interval sports program, I would say you need to be testing. So your football athletes or your basketball athletes, in some capacity before they start some of their contact drills, non-contact drills, at least with some kind of endurance or fatigue program. If you're going to clear a basketball player for shooting, you want to make sure that they're not going to cause a significant tendonitis if they go up and put up a ton of shots and end up having tendonitis and set them back another 3 or 4 weeks, because that's happened to me before. And I think one of the biggest things is making sure that to my fault, I did not do enough testing to see how his endurance was. And when I gave him I gave him an inch, he took a mile, and we ended up getting set back. And then of course the head coach is calling me, asking why he's set back 3 or 4 weeks. So, knowing your interval sports program, using it, and testing along the way. Lastly, understanding the psychological factors. I'm not a trained psychologist. Fortunately, I do have access to 3 that we use in the athletic department. But understanding these things, and this is why I think building the confidence along the way in a shoulder that was previously unstable, or a wrist that always caused pain in this position until they did surgery on it. When you build up that ability for them, and the understanding of how they can progress through this, I think is the biggest thing. And then understanding, again, along the timelines, there's a lot of other factors that you're not considering. You're thinking about their anxiety for competition when they're really just anxious because everyone else is continuing to get better, and they're kind of stuck where they were this time last year, and understanding and working through that. So I think it's always important to bring psychological factors up during your return to sport progression, just to understand that it is a major part of this. And I think it's a lot more major part than we initially realized, even five years ago. So these are the big ones that I see. Lastly, this is the model. This decision-based model was presented, and I think this is still the gold standard of models. And so when I look at this model here and I see functional test, that is just one very, very small factor in my decision to return to play, that decision-making process. So understanding these factors is really what it comes down to. Understanding your sport, the position they play, what's going to be required of them. Can I protect my quarterback in a way that I can't protect my linebacker? That he can do more stuff earlier, and then can I defend my decision on that as I'm going through it? Do I understand the legal ramifications of making these decisions? Am I doing good steps along the way to prove that my athlete is ready to go, and to prove to them that they're ready to go, and then demonstrate that within all of these other decision modifiers that they have. So that's really the last thing I have, and I think it's a good time to open up for questions. There's several references included here at the end, but I think y'all will, if I click through it all, there you go. Now you can have them all because they're all recorded. So open it up to any questions.
So Niles, it sounds like, that's kind of your menu, and you really select what tests according to, the demands of the athlete's sport. And I know that, it's highly variable, but how do you, I guess, balance, wanting to complete and check all those boxes with the realistic time demands? And, objective testing takes time in and of itself, and then it also needs to be planned on athletes' programs. So any advice on how to balance that?
So this is my ignorance of not being in the outpatient world as much, that the time demands are not a thing for me necessarily. If I want to have them test, I can come in and have them test any day of the week, as long as I work it around their class schedules. And I'm seeing them 3 or 4 times a week, so I can easily work in a testing session, or even do one test one day and another test another day throughout the rehab process. So that's, unfortunately for me, that's something I don't have as much experience on. I would say If you're working in an outpatient setting, you've got to prioritize it at least at your stage progressions to go through some of these tests to make sure you're making a clinically based decision, as opposed to just saying they're at the 12-week time, it's okay to begin some plyometric progression. Or looking more so along making some kind of functional decision making, as opposed to just basing it on timelines. So I think that's where you really want to prioritize your time as a practitioner in that outpatient setting to make sure you're getting that in. I see this from Tony looking at the 90-90 ball drop or the dribble test. I did look at that. There was an article. It was part of a battery of tests as well. And so again, it's another one out there. I don't use it. I think the 90-90 ball drop was a good endurance test. And then the wall dribble test as well. But again, it's not one that I've used. There are coming out with a significantly more upper extremity tests that are coming along. Again, not as many of them have been studied. And again, they've just been presented as ideas. So until they come out with more stuff, I have a hard time changing my practice. I just kind of flagged a couple of the newer ones that I think would affect my practice directly. Thank you, Dan, for those references. So my overhead throwers, so my baseball players, or a person that I'm less concerned about having that amount of impact through their upper extremity, I'm not typically doing it with. Especially like my pitchers. I don't think there's as much of a need for it. My quarterback, depending on the type of quarterback he is, our quarterback who last year was extremely physical and was constantly, he ran the ball as much as he passed the ball. And he took a lot of hits. So had he had a shoulder injury, I would have considered it for him. A pocket passer quarterback, and he's really avoiding contact for the most part. I'd be more concerned about just protecting his shoulder overall. And he has a higher ability to protect himself, so I'm probably not using it for him. My volleyball players, I'm probably not using it. And maybe my libero, I would consider using it if she's hitting the ground as much as she is, but my overhead, my outside hitters, probably not.
Yeah, I think that's an awesome point. And like golfers, probably not so much. And, using the scale and the T and the Y tests, even for the volleyball players, maybe a little bit more when they're outstretched and they're just trying to strike the ball like last second there.
Dan showed his video. It means he's about to talk.
No, Niles, that was very thorough, man. Well done, honestly. I was giving you some static last night. We did a good job, buddy. Just a couple comments. First off, I agree with you on I only do the one-arm hop test on contact athletes. So football, wrestling, rugby. I just don't see the value in pitchers, and I would agree with you on that. Secondly, one test you might consider, not only is it just a screening tool in the clinic, it's a really old article, probably before even many of you were born, but the Functional Throwers Performance Index. Basically it's what you do is you're about 15 feet away in the clinic, and you have a square that you put on a wall 4 feet up from the wall. That's a foot by a foot. And the article has a 2-pound ball, but I just honestly use a tennis ball. And it's a really nice tool to practice athletes when they're starting to get back throwing again, because it's accuracy, how many times they can get that ball in the square. And in that particular article, they have norms for male and female athletes. I forgot the ages. And again, some of the numbers are all over the map, but what it does is that it allows you're able to see, and the athlete's able to see that they're able to consistently reproduce that motion. Because as you guys know, when people start throwing the ball at the plyo or the rebounder or whatever, I mean, they're all over the map, right? So this allows you to start, they can, again, reproduction of that same position. The other comment I'll make, and I have no data on this other than just tinkering, and anybody that knows me, I'm a tinkerer. For my upper extremity athletes like post shoulder surgery, I've been doing a 30-second, 20% body weight dumbbell bench and checking the reps. I kind of see that as kind of upper extremity step down test. So for example, if I have a 150-pound athlete, I'm doing a 30-pound dumbbell and we're going 30 seconds, as many reps as possible. The other dumbbell just rests on the other side chest while the other one's pressing. So I've been finding that's again, nice little screening tool just to see where they're at because it's hard to have an open chain test for these other than the isolated muscle tests that you talked about so nicely. So that's it.
Yeah, I think I do like that idea, and it also would almost throw in their endurance in there as well. So over a 30-second rep time, I like that. I do remember, I think Davies presented on the Functional Throwers Index, so I do recall that article. I have not heard anything about it since it was published, so I think that's probably why it never made it into my battery, but I think it is really good, especially for your throwers.
Yeah, and it's not, I mean, they looked at the percentages, how many you should hit, but I think it's one of those ones for us that I think it's super low intensity, so they're not throwing 90 miles an hour, but I mean, at a low intensity in the clinic, A, they like it because it's fun, B, it's objective, they can see it. You know, our athletes love numbers. They love to see improvement, you know, and you count for 30 seconds how many they got, and it's progress, you know what I mean? Like I said, anybody on this call knows that even an improvement of 5 throws from last visit is progress, you know?
I appreciate that.
Niles, good job. Lots of good info there. Couple questions. One is with the, I don't remember what it's called, but the Journal of Hand Therapy, the standing hand grip dynamometer.
Push off test.
Yeah. So I've always done just a screening with a seated long arm, long axis on your fist, or maybe over gripping over a towel, just not a dip, but a press up and for time, and just see how they tolerate it, confidence, that type of thing. So I'm wondering, it looked like they were standing though, is that correct?
Yeah, so the way they described it, the position was basically standing with their fist on a table or a non-slip surface. So I'm guessing they used a mat table for the most part. So it wouldn't kick out, and then obviously you stabilize it to make sure it doesn't twist one way or another. But yeah, it was described I think in that test as standing.
And then I just wondered how many hand grip dynamometers they have to go through when those get broken. Because I could see those breaking.
Yeah, I mean,
yeah, I thought that was interesting though. I think that's an interesting type of test. The other thing, just to expand on the upper limb rotational test from the plank to a wall. Forever I've been doing that, but again in a long arm axis, so press up, push up position with rotation. When obviously like they're ready and that type of thing. So I think either one of those can be, or both can be useful and simple and quick.
Yeah, what I appreciated about and why I included that test in this is, number one, it was new, but number two, it's been an exercise that I usually throw in kind of late stage rehab, doing these T rotations. So they're in that plank position, they reach all the way underneath their torso with their hand, and then they come all the way, rotate all the way back as far as they can go. And I kind of, from my standpoint, I don't do it against a wall. I do it where I can watch them to see how far they actually rotate over that shoulder to see where their confidence level is in the closed chain position. So I included that because it is something that it's kind of one of those things that, you know, you do as a therapist and an exercise progression to see how they tolerate it. But now it's actually being studied as a kind of functional test. So I do think that's a good point.
Right. Yeah, I agree. For what it's worth.
It means a lot, Carrie. Any other questions?
Yes, actually, you and I talked about this a little bit, and I know you're not, no disclosures here with Kaiser. I just haven't looked at him lately. Price, you know, you talk about pricing with Ice Kinetics. What's what's pricing like with those Kaiser machines?
Yeah, so you're looking for the leg press, I believe, was right around 15. So it's still pricey. And again, you know, if you have 3 different units like that, then you're at 45,000. So you might as well have Biodex anyways. So I think that's kind of the big contingency with it. The nice part is it's really easy to set up for therapy, for exercises. I don't know if you ever tried to set it. I mean, I know you do, Carrie. I know you do, Ryan, a little bit of setting guys up on the Biodex for rehab, and it's a little bit of a process. So that's one of the side notes with those. But yeah, if you have 3 units like that, you're probably paying just as much as you would for a Biodex with less study. Tim, is the Proteus system, is that the free motion system? I'm trying to remember. Yeah, I've never played with it. I think Davey's also presented on it. Again, I think he's a consultant for them. But it seems very promising, but I think I don't know what the price point is, but I can't imagine it's cheap.
We had them, they demoed one for us. I don't know, it's probably been 2 years ago now. It was really, really early in development. Yeah, again, a large footprint. Price wise, I don't remember. It was a lot. And then, you know, putting it into, is it going to be beneficial for a lot of folks, or is it going to be beneficial for baseball and tennis, or, you know, that type of thing. So just weighing patient population and that type of thing.
It is something, to be aware of that is out there. And I thought about including that and kind of pulling up his stuff on it. But again, it's not something I'm really familiar with aside from seeing that. I think probably that same presentation as you saw, Tim.
All right. Well, yeah, Niles, that was awesome. I will reference this talk so much with creating return to play programs and decisions. That was phenomenal. So thank you so much for all your time to put your work into that, and also being with on us this morning at 11. So yeah, really appreciative of all that. And we'll upload this just